Thank you, Kate. Johnathon Ross is the past president of Physicians for a National Health Program, a national health reform organization of nearly 20,000 physicians and health professionals. He is a graduate of Cornell University, the Medical College of Ohio at Toledo, and he holds an MPH, a Master of Public Health in Health Policy and Administration from the University of Michigan School of Public Health. He practices and teaches general internal medicine at St. Vincent Mercy Medical Center, a teaching hospital in Toledo. As chairman of the Internal Medicine Department, he has served on the Medical Staff Executive Committee, chairman of the PHO Board of Directors, the HMO, and several hospital committees. He has been a family physician in the National Health Service Corps. Dr. Ross has been the medical director of an industrial medicine concern, a visiting nurse service, a charitable HMO, and a Center City adult medical clinic. As a member of the Ohio State Medical Board, he helped to establish the educational requirements and scope of practice of physician assistants in Ohio. His experience inside the health industry convinced him of the logic and need for a national health insurance program. He is an articulate spokesman for single-payer national health insurance and has published many letters and opinion pieces. Dr. Ross is a man of indefatigable energy. He and his wife Paula have just become grandparents for the first time. His opinion piece, "Let's Celebrate Medicare by Expanding It to Cover Everyone," appears in today's The Blade in Toledo. Yesterday he broadcast a 30-minute radio interview. He was the first visiting health reform speaker that we brought to Louisville, and he made many friends, some of whom were inspired to become single-payer health care reform activists themselves, vis-a-vis Jill Harmler, who had been singing just now. So Kentuckians for Single-Payer Health Care and Physicians for a National Health Program Kentucky are very proud to bring Dr. Ross back to Louisville to celebrate Medicare's 50th birthday. Johnathon Ross.
I was telling Garrett the other night, we're up in Toledo when these folks, wonderful folks down here in Louisville, found a nasty person here, somebody. I can't find one. That's wonderful. But there's probably a few, but I think there are probably fewer than in most places. But I was telling Garrett, no one had a whole lot of enthusiasm up in my area for this Medicare's 50th birthday party. And about 2 days after I agreed to come down here, all of a sudden everybody got excited. So I'm missing the birthday party in Toledo, which I helped to organize over the last couple of weeks. So we'll get some news from them. I was almost thinking, hey, they'll pull up a phone and let them all say hi to you guys, because people still know a good thing when they see it, and certainly my parents, my grandparents have benefited greatly, and now myself, I just turned 65 this year. So, here I am, and Paula, my wife, is here as well. We're on this program now and feeling like I now have not just want to say I think it's the best model for improving and expanding healthcare across America, but hey, I'm going to be part of this whole thing, so I want it to work for me too, so I can have a dog in the fight now. So what I'm going to do is I'm going to run through kind of the history of how Medicare came about, because there's the old saying, if you don't know history, you're doomed to repeat it sometimes, and I can tell you we've been repeating it when it comes to healthcare reform. So let's see how this thing goes. Anybody recognize this guy without reading the fine print? That's Niccolo Machiavelli. Machiavelli has kind of a bad rap, right? He actually wrote a nice book called The Prince. He was an advisor to one of the Italian princes in the Renaissance, and he actually gave some pretty good advice. And you can read this because I think it's really pertinent to what we're trying to do with healthcare. There's nothing more difficult to plan, more doubtful of success, or more dangerous to manage than the creation of a new system. For the initiator has the enmity of all who would profit by the preservation of the old system, and merely lukewarm defenders in those who would gain by the new one. So, if you think about that, there's some wisdom in that. And And again, that's what we're trying to do. We're trying to displace people who are making tens of millions of dollars from their pile of cash, right? And so they're going to fight us. We're currently spending $3 trillion a year in America on healthcare, $3 trillion every year, and those guys walk away with a percentage of it. Why would they ever want there to be less money spent when they walk away with a percentage of it? It's our job to make sure that that percentage of administrative costs is the lowest it can possibly be. Here's another guy who had some wisdom. Maybe not, anybody recognize this guy? That's Otto von Bismarck. That's who that is. That Bismarck was the Machiavelli to Kaiser Wilhelm II, okay? And he said, laws and sausages are two things you do not want to see being made. And certainly, by the time I'm done with the talk, you'll appreciate it a little bit more when it comes to making healthcare law. How about this guy? Teddy Roosevelt, right? Why did I put Teddy up? Anybody know? He was the first presidential candidate to recommend that we have a national health system. The first one. It wasn't when he was a Republican or a president. He actually was back. He had been to Germany already. And over in Germany, he had seen that they already had a national health system. That system was put in place by Bismarck and Kaiser Wilhelm II. Both Social Security and a health system were put in place because they were worried about socialist revolution over there. And so the people were up in arms a bit, and they decided this was a way to palliate the masses, was to make sure that they at least gave them. Now, why did they pick age 65 for Social Security in Germany then, you know? Almost nobody lived to be 65. They thought, we'll never pay a dime, right? It's like, you know, insuring pig iron underwater against fire, right? And never pay a claim.
Right.
So anyway, but Teddy was the first one to talk about it because he'd been over there and seen it, right? Now around the same time, there was something called the American Association for Labor Legislation, AALL, and they were proposing things like Social Security and a national health insurance program, workers' compensation for injured workers. A lot of these things came out of the AALL in the 19-teens. But of course, something happened not too long after 1911. This, right? That's Germans and their gas masks and their machine gun masks. And anything that was a German idea was going absolutely nowhere, right? You know, we just been in the middle of a war with these guys, and so anything German was not. My grandmother's name was Celesky, and she came from the part of Germany that was always fought back and forth over between Poland and Germany, right? So when World War I happened, they made sure that we were in an SKI, not a Y, because that's how you could tell it was that. She told me. Anyway, so yeah, nothing German was going anywhere. Another guy, anybody, well maybe Garrett might know this name, I don't know, but this is Abraham Flexner. Abraham Flexner was a physician, and up until around 1910 to 1920, you were actually better off to stay home than go see a doctor. Because many of the doctors were not trained scientifically, and a lot of it was apprenticeships and things along that line. You really couldn't be sure. There were diploma mills where, you know, you send them $1 and they'll send you a medical diploma. I mean, those sort of things. So this was a real problem in America. And this guy, you know, and a group of his colleagues, there was a study commission, and they looked at it and said, you know, we want doctors to be trained scientifically, and we want them to have the basis of medical care be in the science of biology and medicine. And so what happened was, is in 1918, there was a report that put out, and basically a lot of these diploma mill medical schools and apprenticeship sort of deals went away. Now, the other important thing about World War I is that the other thing about World War I was millions of Americans were, both men and women, went into the armed forces. When you go into the armed forces, has anybody been in the armed forces? Actually, yeah, you have. You know, how many shots did we get? I mean, more than you can count. I mean, they probed you everywhere. I did it because I was in the National Health Service, which, believe it or not, is a uniform service. So I had to go to one of the public health hospitals in Boston to get my physical. But they probed and shot and everything else. But this is the first time for many Americans who were involved in World War I. It was the very first time they actually were exposed to scientific medicine. And they saw what surgery could do to their injured colleagues and what medicine could do for their injured colleagues. So this, not only the technology was advancing, that we had more things we could do that genuinely helped people, but more people had been exposed to it, and now there was demand for it. So soon after this, in the 1920s, healthcare costs were headed for the moon already. And they actually had a national commission called the Commission on the Costs of Medical Care that was formed. And they looked into it, and they delivered their report just beyond 1930. I'm going to back up and talk about Justin Ford Kimball in a second. But
In 1930, as you all know, we were already into the depths of the Depression. So when they brought forth their report, what they said was, we should have an organized medical system. And everybody should be able to get into it, and the smartest way to fund it would be with everybody paying some sort of premiums or taxes to fund it. Nothing complicated, basically what Medicare is now, right? That was what they recommended. But no money to do anything in the midst of the Depression. But people still needed medical care. And again, we have American ingenuity. This guy, Justin Ford Kimball, was actually the head of the Texas State Teachers before he got a job as the head of the Baylor healthcare system down in Texas. And one of the things he noticed when he took over the Baylor healthcare system was that people could not afford to pay the hospital bills when they got in there. And he knew the teachers union quite well, and he went to them and said, for 50 cents a month, I can cover 21 hospital days here at Baylor for you. Now, this is old money, right? You do the math on what that would be today, but that still sounds like a pretty good deal to me. What happened is that turned into the original Blue Cross. And again, Blue Crosses were all organized as not-for-profit, public service organizations. None of them were for-profit insurers at that time. They were all organized to benefit their communities. And so this guy, Justin Ford Kimball, proved that people were willing to kick in or chip in. And of course, as you know, Blue Cross grew and grew, and it became the dominant insurer through the 1930s, 40s, and 50s in the U.S. So there's good old Texas Blue Cross symbols now. So this guy, you all recognize him, right? We talk about the 1930s. Of course, we were in the depths of the Depression, and the question was, what should we do? And of course, FDR put the works projects in place. In Toledo, we still have a nice set of zoo buildings. We have a bunch of parks where the WPA still built buildings. I don't understand why the right wing did not think, when we were in the depths of the closest thing to the Depression that we've had since the Depression, that a public works program didn't make any sense. We certainly should have been spending money on public works. My goodness, Paul, we saw public works on the way down, didn't we? The traffic between Toledo and down here for the construction, you'd think they were redoing the entire highway system. But it's a good way to put people to work for stuff that we all want and need together anyway. The sewers, the roads, those are things, the bridges that we need to keep up. Well, Roosevelt decided to go ahead and put people to work. It made a huge difference. And certainly by the mid-1930s, they were talking about the expansion of social insurance in the form of Social Security. They were talking about workers' compensation, and those are the things that went into the New Deal at that time. Now, Roosevelt also wanted to do a national health insurance program, but one of his best friends was Dr. Morris Fishbein. Dr. Morris Fishbein was head of the AMA. And he said, look, you want to get these other things? The AMA is going to come out hot and heavy against this. There's no way they want the government coming anywhere near medical care. You'll lose the other things if you don't let it go. So although a national health insurance program was part of what Roosevelt wanted to do, he dropped it, and indeed he was able to get Social Security's workers' comp and a lot of the works programs in place that helped us get out of the Depression. Well, about that same time, there were people still thinking about a national health insurance program and wanting to put it into legislation. And this gentleman, Senator Richard Wagner, decided that he was going to write it up as a bill. So our first official entered into Congress national health insurance bill was the Wagner Health Act. And it got looked at a couple of times in the 1930s, but never really brought to bear. His last attempt was in 1939. It was actually on the floor in Congress in 1939 when the war, again, World War II this time, broke out. So again, nobody was going to pay too much attention to social policy when the world was in flames in World War II. So there's Rosie the Riveter. My new granddaughter's middle name is Rose. I just realized Rosie. We can do it. And the reason I put Rosie up there is because the fate of the American healthcare system to some extent was sealed during World War II because they put wage and price controls in place. And when they put those wage and price controls in place, they did not put benefit controls in place. And again, there was a worker shortage. That's why I showed Rosie here, because a lot of women went to work because the men were off fighting in the war. And the unions really had an opportunity at that point to bargain for benefits. And one of the benefits that they bargained for, because now we've seen it can be done through the Texas State Teachers and Blue Cross, was health insurance through your work. And that's how America ended up linking our insurance to the workplace. None of our other economic rich competitors decided to link health care to the workplace. And of course, linking healthcare to the workplace is a really bad idea, because if you lose your job, you lose your insurance. And it's the natural thing in a competitive economy that we have, that people are from time to time going to lose their jobs or change jobs and fall into the gaps that are there. So most of these other countries had the common sense to realize that healthcare ought to be something that's associated with your citizenship or your residency in the country and not be hooked to your work. But because of this accident in World War II, that's how it was. Very true, given healthcare. And he tried, actually, to get the Wagner girl passed twice. Both times, these guys showed up. Okay. The AMA was really worried. They actually said that Harry Truman was getting his orders straight from Moscow, things like that. They were shameless in terms of the way they talked about Harry Truman when it came to national health insurance. But Harry tried twice, and most people who, we'll show you his picture one more time before we're done. But the AMA stepped up. They spent one of the largest lobbying campaigns that had ever been in the history of American politics to try and kill it the second time. Harry tried, couldn't get it. Well, then we get to the 50s, right? And the 50s were kind of a boom time. We were out of World War II. We still had some concerns with Korean War early on. Republicans were now more in charge, so there wasn't a whole lot of social programs that they wanted to talk very much about. But throughout the 1950s, trade unionism became, kind of at its peak. 30 to 40% of American households had some minimum that was a union. And so this is a picture from Labor Day parade in Detroit. This is the Bakers Union saying thank you to everybody who's eating bread made with union labor. So this is the bakers marching in the street. And so I put them up there because one of the things that happened, of course, with those unions is they had already figured out that they could get benefits, including health benefits, as something they could bargain for. And they continued to bargain for it throughout the 50s. So many, many more working people were able to get health insurance through the job because of what the labor unions were doing. And so it kind of became even more standard that our health insurance would be associated with our working lives rather than with our citizenship. Anybody recognize him? No, that's Wilbur Mills. Wilbur Mills was incredibly powerful. He was the Ways and Means Committee chairman for longer than anybody had ever been and will probably ever be in the future. He sat there for almost 20 years in that seat in Congress as chair of the Ways and Means Committee. And Wilbur actually was interested in health policy, but he was even more interested in being fiscally conservative. He was considered the tax expert of Congress and the financing expert in Congress. And so he was highly respected by his colleagues for those things, although he was a bit of a character. We'll talk about that. Maybe you guys remember. Yeah, we'll get there. So Wilbur actually was being, all the Congress people were being pushed pretty hard because at this particular point, it was really clear who was hurting in terms of healthcare in America. As I said, many people were not getting healthcare through their union-based jobs or because the unions got it, other companies were giving it even to non-unionized people. We have a lot of people who were poor and a lot of people who were old who could not get insurance. Now, you'll know here with the Affordable Care Act recently, one of the big deals about it was the fact that they could no longer discriminate against people with pre-existing conditions. Well, back then, being old was a pre-existing condition. If you were old, private insurance was not going to sell you insurance. They were going to restrict it, especially the ones that, about this time is when the Aetnas and some of the other guys began dabbling in the health insurance area. So Wilbur Mills understood that this was a problem. There was tremendous pressure to do something about it, and it was kind of all marching forward from Teddy Roosevelt all the way through the Wagner Health Act and Truman's couple of attempts to try and do something about it. So Wilbur said, well, why don't we send money, this will sound familiar to those of you who know about the Affordable Care Act, let's send money to the states, and we'll have the states dish out that money to poor and needy seniors to help them with their hospital bills. And that was called the Care-Mills Act. Okay, it was passed in 1959. So it's just a small problem. Many of the states didn't take the money. In the few states that did take the money, it's not like the ACA there, some of the states that did take the money were really restrictive. They said, oh, if you take this money, then when you die, we're taking your house, things like that. So it was not a great success. A very 1 to 2% of the people who could have benefited from this actually benefited from Care-Mills. So he was kind of disappointed that it hadn't worked out. You all know him too, right? That's John F. Kennedy, JFK. Well, right around the same time, JFK decided that he was going to ride this horse, that he knew that people were demanding something be done for seniors, and he actually stepped up to the plate. He was probably not interested fully in a national health insurance program, but by 1962, he was publicly speaking about it, and certainly in the Nixon-Kennedy debates. At that time, I was 10 years old, and my next door neighbor was a cardiologist, and he was all up in arms about Kennedy. He was all worried, that Kennedy, this is the latest communist plot would be to take over healthcare. And so it was the same sort of talk that had been going around back when Truman was around, and even if you want to go all the way back further to when FDR was proposing these things. But unfortunately, of course, the AMA wasn't going to have anything to do with this once again, and they actually hired a B-movie actor later to become President of the United States, Ronald Reagan, to make a record which basically accused Kennedy of communist leanings, all this. It's the first step to socialism. This was, you put that little bait out there for people, on healthcare, and the next thing you know, we'll all be, working in a commune. That was kind of their attitude about it. And he actually made an 11-minute record, and the AMA passed that record out to all AMA members, and their wives were supposed to have coffee klatches and talk to the other wives about how this idea of Medicare was a bad idea. Well, Kennedy, of course, was assassinated in '63, and LBJ, Lyndon Baines Johnson, succeeded, and there's Jackie Kennedy, his widow, standing next to him as he took the oath of office. But LBJ was a very crafty man, and he knew Congress inside and out. He had dirt on everybody, too. So he really knew how to get things done. And the other thing that was important was this. Everybody recognized him. That's Barry Goldwater, right? And everybody was afraid Barry Goldwater was going to start a nuclear war. And Johnson had a sweeping victory in 1964. Up until this point, Medicare, the idea behind Medicare, was still bottled up in Wilbur Mills's committee. And it wouldn't get out. And Mills told Johnson before the '64 election, I'm not going to even try. I don't think we could get the votes together to actually pass Medicare, but let's see what happens with the election. I think Mills did not think that the election would go as strongly as it did for the Democrats, but it did. They had a dominant majority in the Senate. Basically, there was nothing that the Republicans could do to stop Medicare at that point once that election happened. Now, they had alternative proposals. You all remember this guy? Yeah, it's Gerald Ford. Gerald Ford, actually, the AMA gave him legislation that would cover not just hospitalization, which was what Kennedy was promising, that we would have universal hospitalization for people over 65. But he was saying, well, we could do better than that. If people were willing to pay premiums, maybe we could have this thing called better care, which would be cover doctor bills as well, which of course the AMA was all excited about having the doctor bills covered, so they were more enthusiastic about that idea, and about having it all be premium-based rather than tax-based, okay? So these were the ideas that were kicking around. So then comes Wilbur back again, okay? And Wilbur hears this. He's already got Care Mills, which is a program for the poor that he's put in place. And he knows about Medicare, which would be tax-funded, tax-financed to cover hospitalization. And he's got the AMA, and to some extent the Republicans, backing the AMA's idea for premium-based payments for doctor bills. What we end up with is the three-layer cake, okay? There's another Wilbur Cohen, who was the head of the Social Security Administration at that time. And he was trying to get Wilbur to move this bill out of committee, and they decided that they would go for all three. They would make the Care Mills, expand Care Mills to cover all the poor, not just senior poor. They would use the tax financing of hospitalization for Part A of Medicare, and Part B would become premium supported. So those of you that are on Medicare know that they deduct a certain amount from your Social Security check to cover your Part B premiums if you choose. To some extent, it's voluntary. Only a fool would probably, or a very rich person, probably would not choose to take those voluntary premiums because it's part on Part B. So that's how we ended up with Part A, hospital, Part B, doctors, and Medicaid, which is also 50 years old today, the Medicare program, Medicaid program, which is mainly for people that are poor, and Medicaid became a key piece of the ACA, where the majority of people who were getting new coverage were actually being covered because we decided that being a little bit above the poverty line was something that where maybe healthcare would be hard to afford as well. And the ACA pushed it up to 138% poverty. So we have this Medicaid expansion as part of the ACA. So that, I should have made that bigger. That's not easy to see. That's LBJ again. Do you see who's over there by him? That's Truman. He had Truman at the sign. Because LBJ knew who was the guy that had really tried extra hard to get something done. And actually, the very first Medicare card went to Harry Truman.
Wow.
So that's, he got the first card. And what, about the horrible rollout with the ACA, all these crazy glitches. And again, Medicare is pretty simple. Everybody was going to get the same thing, relatively comprehensive coverage for hospital and doctors if you so chose by having the deductions from your Social Security check. So it was relatively straightforward, and they were able to enroll the vast majority of people on 3x5 cards in just a few months. There was no glitches, no screw-ups, these crazy markets and all the other things that these guys like. So here's another guy. Kennedy was a rising star in the Senate and was threatening to run for the presidency, and again was talking about national health insurance. And Nixon was going to his advisors and saying, we gotta have something. We gotta have something on healthcare. Kennedy's gonna beat me up in the debates when they happen. And sure enough, he decided that Kennedy would turn once again to Wilbur Mills, who was still head of the Ways and Means Committee, to actually discuss this idea again. And see, I kind of got myself out of sequence. We'll get back to her. But so one of the things that everyone, where did HMOs come from? HMOs came from actually a bunch of people who really believed that we should have healthcare as prepaid, no money at the point of service, and these were doctors who were actually ostracized by the ANA, and they were people like the Kaiser Health Program and other not-for-profit insurers that actually hired doctors and actually provided care. They were considered leftists at that particular time. But what Nixon had heard was that HMOs were giving better care for less money, and that's all he cared about. And so he had some colleagues, there's a guy named Dr. forgetting his first name, his last name was Elwood, and they managed to get the HMO Act passed in '74 as a counter to this threat from Kennedy, once again, to the younger Kennedy, to have a national health insurance program. He also, and there's a wonderful video of him doing this, of his speech, he also proposed Obamacare in 1974, which is that we would give subsidies to low-income people to purchase insurance through marketplaces, that you ought to be allowed to market your insurance everywhere. Right now, each state can regulate insurers, and some are much better at it than others, I'll say that. But he was there again proposing, throw that all out, no state regulation, so of course you probably have the regulation of insurance companies sink to the lowest common denominator in whatever state would give them the freest hand. But he also proposed Obamacare at that time. So Obamacare then became Romneycare in Massachusetts, which eventually became Obamacare again. So how the Republicans can be so upset about an idea that has such Republican traditions, I don't understand, but they did. So there he is, and there's Wilbur again, right? So they were actually conniving about putting together a national health insurance law in 1974. But Wilbur had a problem. He had a problem with bottle, and he had a problem with her. That's the Argentine stripper Fanny Fox. And he ended up in the waiting pool, the reflecting pool, with the cops on his tail, and that was pretty much the end of Wilbur Mills's career. And then, of course, the other thing that happened was Nixon was in trouble with Watergate and got impeached. So, in some ways, I feel a little bad about Nixon's not very, but a little bad about Nixon's. Primarily because we would have had Obamacare a long time ago and been over it by now. So that's one of the things that kind of comes to my mind when I think about this, because that's basically his national health program was Obamacare. So I'm going to run through, since then there's been a bunch of amendments. Medicare has been durable, it's been flexible, it's been able to adapt to things that were going on. Renal failure patients were not covered at first. If you were, then they decided, hey, we need to cover people on renal failure because they were dying without dialysis. Dialysis was quite expensive, and Congress pushed through an amendment to get renal failure on there. And around the same time, anyone who was under age 65 but was permanently disabled, meaning unable to work for at least 2 years, completely and totally disabled, and then you would get Medicare. And so all that stuff came into being, as well as I mentioned Nixon's proposal for HMOs, very close to that in '74. Hospice care got added in 1982. Medicare has been one of the more innovative programs. It's led the way in terms of thinking about cost control. And one of the things that happened with Medicare that was actually quite a problem is that in trying to buy off the AMA, and to some extent the hospitals, they said that Medicare would pay usual and customary charges, which basically meant whatever the hell you guys want to charge us, right? And so, of course, you put the box in with the chickens and chicken soup, right? The foxes really did go ahead and begin to push up the cost of medical care pretty rapidly after Medicare. People were benefiting, there was no question about that, but we didn't really have control over payments. So the first place they went was the hospitals, which is the biggest piece of what we pay. And they said, rather than paying you whatever charges you want to send us hospitals, we're going to give you fixed payments. We're going to give you a per diem, this amount of money per day in the hospital. People began to behave a little bizarre in regard to that, with how many days. They would just string out the days sometimes, so it was still a problem, but at least it was limiting some of the costs. In 1988, because people were still facing a fair amount of out-of-pocket costs under Medicare, they actually passed catastrophic coverage. But rather than spread it over the entire population, right now everybody who sees HCFA on their paychecks, they're all paying for Medicare right now. That money is being kicked into the Medicare system. And so we all pay a little bit all the time to support the Medicare system. And what's going on in this time is that there's still a fair amount of high ticket costs happening for a small number of seniors. So they tried to put a catastrophic package in place, but they tried to make just the seniors pay for it. They didn't ask anybody else. So the premiums are pretty chunky, and people got really angry, and they had to actually back off and cancel that legislation, even though it was relatively wise. Again, if they just simply spread the costs over everyone rather than just laying it all on seniors, it probably would work fine. The Balanced Budget Act in 1997, they went even further with hospital cost control. They began to look at paying hospitals by the diagnosis so that they weren't running out the hospital days. So at first they were just charging whatever, and then they were running out the hospital days to as many as they could. So then they said, no, we're going to give you a fixed payment for that case. In the case of pneumonia, fixed payment. In the case of heart attack, fixed payment. So for each of the diseases, they created a diagnosis-related group payment for them. At that same time, when all these things came into place, the Republicans pushed through something called Medicare Plus Choice, which has subsequently become Medicare Advantage. Are any of you on Medicare Advantage plans here? I think there's a few. Yeah. They're private insurers who Medicare hands over a fixed amount of money per person per month to those insurers. It's supposed to reflect the cost of their communities. So, but it does pass the responsibility over to the insurer. And to some extent, these are, so you're kind of back into some of the same issues. Although the law does say that they have to cover everything that Medicare says they are supposed to cover. And they were supposed to do more. The original one actually said that they were going to take 5% less to be in the program. They had to take 5% less per person per month than the standard Medicare program in the area they were in. That went away in a hurry. And now probably 14% above the average cost in an area. And we can't seem to get it reined in because, of course, the insurance companies are very powerful lobby. The Medicare Modernization Act added the drug coverage, and as most of you know, that's younger Bush. And when that went through, I was just shaking my head because here we have an opportunity to actually negotiate for drug prices, and instead the law explicitly says that the government is not allowed to negotiate on behalf of seniors for their drug prices. We do that already in the Veterans Administration. The veterans, already are involved in negotiating for medicine costs, and their medicine, the cost of medicines in the VA is probably about half of what it is on average out there in Part D. But again, it was a Republican bill, and it was probably written by the pharmaceutical companies, and that happens a lot in Washington, where the people who are going to be regulated write the regulations. But we ended up with Part D, which was better than nothing, but still had this big old donut hole in it. And I don't know if anybody in this room has had a friend or someone else who's fallen into that donut hole. I've had a few patients who get sick every November because they can't stay on the expensive medicines around. So we have to make sure, now that we know that that's going to be the case, to get out in front of it and try to get freebies if we can. But, the work that goes into getting that free medicine doesn't really make it free anymore. It's like I could give you guys this library building. There's just a few things about it. You can't move it, touch it, use it. You tell anybody it's yours. You get the idea. I mean, that's kind of what free medicines from the drug companies are like. They really make it tough sometimes. Then we come to the Affordable Care Act, and it did help Medicare because, to some extent, it added free preventive services. It's slowly closing that donut hole in Part D in the drugs. And we've got this committee on medical innovation. Medicare and Medicaid innovation, which might lead to some new ideas for trying to improve services and improve costs. So there's a few things in there that have definitely altered and improved Medicare's finances. And then lastly, we have the back fix, and I don't remember, the bill is called MACRA, I don't remember what all that stands for. But that was because they had put some price controls on physicians and that never stuck to it. Every year they had to kick more money in and kick more money in, and they were actually building up some debt on the books that they needed to resolve because they weren't willing to step up to the plate and just deal with putting a little better controls over physician income on Medicare. But when that got fixed, it did lead to a real problem in Medicare, and it'll sneak up on us. And that is that they're going to go to income-based premiums. And those income-based premiums are not going to be adjusted for inflation. So much like in the Affordable Care Act for people who have union benefit plans, where the insurance is eventually going to get taxed at a higher and higher rate for businesses. Right now, a business buys health insurance for you and your family, and you kick in some money, all that's tax deductible. And they're putting a cap on that within Obamacare. It's called the Cadillac tax, is how it's called, although many of these plans I hardly feel are Cadillac in many ways. We still have lots of co-payments and deductibles and out-of-pocket costs as part of it, but they're not going to index them for inflation, so that'll mean that as medical inflation continues, that more and more people, they're working people with union-based or company-based benefits, the companies are going to be trying to cut back because suddenly they're going to be taxed on those benefits, where they weren't taxed before, they were considered tax deductible. Similarly, we'll see this with Medicare premiums because they're not indexing those for inflation. So there's a couple poison pills in that Obamacare legislation that need to fix them. And it isn't just me who believes that. It's 20,000 other of my colleagues in the National Physician for a National Health Program, and lots of people in this room who've read enough to understand it. It's simple. It's simple. The simplicity is the great thing about it. Comprehensive coverage for what you need. One good comprehensive program for everybody. One set of rules for all the hospitals, one set of rules for all the doctors. That simplicity saves so much money, it's astounding. It's always been an efficient program. The trustees say it's about 2 cents on the dollar goes to administration within the Medicare program. And the typical private health insurance numbers for the not-for-profit insurers are probably in the 10 to 12 cents on the dollar. And for-profits are probably in the 15 to 20 cents on the dollar for the big ones. And the people who used to do individual policies, like they're selling on the exchanges now, Obamacare, some of those were 50 cents on the dollar went to administration and profit. 50 cents went to their pocket rather than health care. I don't know whether that could really be considered insurance or not. The other thing is that Medicare is a guarantee. It gives us security. We know it's there when it's not likely to be pulled away, and people will defend it. People understand it enough to defend it. So it's a good model from that perspective, in the sense of saying we're going to guarantee it to all without the exclusions, without the pre-existing conditions. And this is something Medicare's never done. Everybody was in, nobody was on. It's comprehensive. It covers all the basic services that we need. It could be more comprehensive because Medicare still has co-payments and deductibles, although they're fairly affordable unless you're really drastically ill and are in and out of a doctor's office in the hospitals. You can't make up enough out-of-pocket payments. Or if you don't happen to purchase a gap policy on the doctor bill side of things. Because if you've got Medicare Part B, but you don't have coverage for the additional 20% that Medicare doesn't cover for your Part B premium, you can get hit with pretty outlandish fees. If you have a long-term illness with a lot of doctors involved. Many of you in this room probably understand that. It does limit out-of-pocket costs. It can be limited completely. Most people, my experience with co-payments is they kill people. That's my experience. They kill people. People think, oh, I can get by. This isn't anything dangerous. This pressure in my chest. should come get checked. You know, you shouldn't have to think, yeah, it is, no, it isn't. All these ideas of giving us skin in the game, right? That's what I hear. You know, oh yeah, patients need skin in the game. They need to have some money on the table so they'll use healthcare more effectively and efficiently. We know who'll get skin. You know, it'll be the patient. That's who'll get skin. And so I just have seen so many patients make a bad decision. Even people with pretty good insurance, where the co-payments are what you might even consider fairly reasonable, will sometimes balk at coming to see a doctor or going to the emergency room with a problem because they're afraid of a $50 or $100 co-payment, which might save their life. So I just don't think payment at the point of service makes any sense at all. Why would you, you know, if you knew whether you ought or ought not to go to the doctor, you know, then you'd have MD after your name or DO or something along that line, right? You know, so most of us really need that advice, especially primary care. It's particularly stupid to make people pay to come see their first line family doctor or primary care provider. You know, I don't know, Paula really does this more than I. She's the budget person in the household. She's got the MBA. But you know, to some extent we live within the budget. Paula figures out what we're spending on what and pays attention to it. Our problem with our healthcare system is we have no control over the spending because there's no budget. No one is looking at it and saying this is appropriate or inappropriate spending. It's just hodgepodge, craziness, you know. We don't track who's spending what on anything. And it's all in private hands, and you know, so the private insurers aren't very happy about sharing the data. They consider that business information. So the problem here is we can't get a hold of things, we can't set a budget, we can't really predict costs, which make it really difficult. But when you have a national health insurance system where everybody's in and nobody's out, it makes the costs much more predictable. You know, the bigger the numbers that are involved, the more predictable the likely outlays for healthcare. So we can get more predictable. We can begin to look at whether the technology and the infrastructure, the hospital buildings, the MRI machines, the CT scanners, are they proportionately out there where they belong in proportion to the population and in proportion to the likelihood of their need? And we don't do any of that. It's just this hospital wants to buy it when they buy it. You know, I don't know, we used to have something in Ohio called certificate of need. If you wanted to spend more than $100,000, it had to go through a public committee. That's gone. You know, they want to spend money on something stupid, they will. And so we don't have any public oversight, no public accountability, but Medicare would give us that. The financing is fair in Medicare because it really is a graduated financing based on what you earn over your lifetime. It could be fair or even because some of the payments stop in the low $100,000 range. So Don would bat mouth, put your foot in it. I think he's old enough to be on Medicare. I wonder if he can confess to that. But anyway, he's not paying his fair share. He's not paying his fair share. So, and if we had everybody kind of paying proportionate to their wealth, I think that we could have an absolutely fair financing. And again, Medicare will give us that for all, will give us that option to make that fairer. And then lastly, Medicare doesn't tell you who to go see in terms of doctor. Now, the folks here who said they are Medicare Advantage, you may have limitations on that. Within the Medicare Advantage plans, which are the private insurance substitutes for traditional Medicare, they might tell you, no, you can only use this hospital, use this doctor. And they do it promising you that, that if you do that they'll give you a lower premium for it. But again, it's turned out that these private substitutes are about 14% more expensive than traditional. Take the same people who put them in traditional Medicare, we'd save 14%. And they were supposed to take 5% less. And the last time we tried to argue with it, at least Congress tried to argue down, or the people at HEW, Health and Education and Welfare, tried to argue the insurance companies down. They fought it off and they got a premium increase anyway, even though they were already overspending proportionate to traditional Medicare. So when they take an extra 14% for the people that are on Medicare Advantage, all the rest of us are going to pay for that to some extent, for that waste. So a choice of provider. I mean, I can't think of anything worse to be in a situation where I couldn't have some element of control and choice over who was taking care of me when I was sick. That would be a scary thing, to be quite truthful. And most of you, if you've had any kind of illness, that once you get somebody who's pretty good and you trust, you want to stick with them. And so the insurance companies are always trying to mess with that. They're always trying to get you to go to their panel of doctors, because they're bribing the doctors, right? They're trying to pay the doctors to take a lower fee if they'll take more patients, and they're thereby by using money to force you to see a doctor that you don't know or you don't trust. So I'm going to throw a few extra slides up here from Physicians for National Health Programs. Maybe somebody will have seen this, but I think it's important to recognize that Medicare has consistently had lower cost growth. If you look at the average annual expenditures from 1969, 4 years after Medicare got started, through to 2012, Medicare's average cost inflation has been about 7.7%. Now that's still way above national inflation. It's still, a problem even at 7.7. But if you look then at private insurance, it's been at 9.2%. If you actually do the math on this, it's trillions of dollars, that got spent on private insurance, that if it had been the same cost growth in Medicare, literally trillions of dollars would be being saved at this point. And if you're spending $3 trillion, we might be closer to $2. And that's the difference in that. So it's huge. It's the compound interest issue. Here's the Medicare Advantage stuff I was talking about. So the private subsidies for Medicare, the administrative overheads in those private plans average per person in profit, average $1,450 versus Medicare at $147 per enrolled, the traditional program. So huge differences in overhead that happens in that program, and we can't seem to rein in the costs over there because they lobby Congress and get there. So here's kind of the buildup of these overpayments, starting from the way back. So if we come all the way back in here, where we were first looking at Medicare, and these creatures didn't exist, the first thing the insurers started doing was picking healthier people. So we know from the early experience with the original Medicare Advantage plans, which were called Medicare Plus Choice, that healthy people would enroll, and then when they would get sick, they would be encouraged to drop and to go out and to go, you can't get that surgery from the doctor you want to get the surgery. Well, you could drop the HMO and go back on traditional Medicare. So what would happen is the sick people would end up back on the public dime, and these private insurers would get to keep the difference. The next thing, so that's the purple, is all this cherry picking, which is picking the healthier seniors. I don't know the couple of you that are in the Medicare Advantage plans here, do they have an exercise benefit? Do they give you a health club?
Yeah.
Okay. What do you think that's about? Who's going to use the health club? Healthier people, that's who, right? All the advertisements in my area, you see these smiling grandmas and grandmas, I guess I'm right from them, pushing their grandchildren on a swing, they're out jogging, they're not marketing to the raging grannies, I'm sorry, they're not, And think about, they market door to door or directly. They don't market, broadly, they market pretty targeted. And who's not home? People in the hospital. Who's not home? People in the nursing home. And who are they? The most expensive of us. Right? So they've been cherry picking like crazy forever. I saw this happen, and I worked for a Catholic hospital, and I saw that HMO that I worked with, which was a 501c3 charitable HMO that had to give any profits or excess that it kept to charity. I watched them make decisions about cherry picking. We marketed our Medicaid product door to door because you could watch the person walk to the door. Literally, they said that in the room. I was sitting in the room, my jaw fell. Right in front of the nuns, they said that. And nobody, I took a $30,000 salary cut not to do that work. I could not be part of it. When you can't even trust the nuns to say you were that seriously, you know they were all bought and sold and paid for. And now we've got this legislative increase that's happening for these guys. So they're ripping us off. I guess that's, and prove to us, what the level of illness is on these patients, because we're going to modify the premium now by how sick the person is. So we won't let you really cherry pick anymore. So they just lied about how sick people were. They just told Medicare that their people were sicker than they were. So it turned out that the diagnoses they said their patients had were supported, and it ended up being about $2,244 per person they enrolled in this particular unit called Pacific Care. So they got fined for it. But bottom line on it is they're going to cheat. They're going to cheat. So here's what these guys get paid to cheat. I'll just let that sink in. I don't have any comments that can say more than this. Here's the United Healthcare guy, right? There they are stealing $2,000 per enrollee, and he's making $238 million in stock options and $12 million a year.
Enough said. That's Sylvia Burwell. She's Secretary of Health and Human Services. Anybody know who paid her? $203,000 for all of Medicare. She runs all of Medicare. She gets paid $203,000. Now she gets probably free plane rides and a few other things. But and she gets to hang out with Obama, maybe shoot some baskets. She's an athletic woman, by the way. She really is. I think she's a runner. Anyway, so we don't have to pay people $10 million or give them $250,000 in stock options to get good people to run our healthcare system. We don't have to do that. We don't have to do that. But we let them do that. Because if we don't demand no change without a demand, no change without a demand. So we have to demand it, and we have to call them out. We have to call our legislators and others out if they don't do something. So again, simplicity, efficiency, guaranteed, comprehensive, limited out-of-pocket costs, good cost control, fair financing, and choice of the doctors and the hospitals we want to use. So we can either have, I'll say, their reform, which is you choose your insurer, not your doctor. Your coverage is co-payments and exclusions, that you might not be happy with when you find out your doctor's not part of the network or whatever. Their idea of security is you lose it if you can't work or you can't pay. And their idea of savings is you get less care. That's where they want to save. They want you're the bad guy. Those patients and doctors, they're just doing too much care. I could have a whole other set of slides which I could show you that just shows it comparison after comparison after comparison. We do not use more hospital days. We do not go to the doctor anymore. We don't do more renal transplants. We don't do more bone marrow transplants. We don't do more research on a per capita basis. We don't. Our economic competitors cover everybody for half of what we spend and do better on all of those things, including living longer and better lives. So no, we don't have the best healthcare system in the world, but we could, because we've got some of, if not the best doctors in the world. We've got some, if not the best hospitals in the world. We've got research capabilities because we're big and rich that most other countries don't have. We've got the best nurses in the world. We've got just an amazing array of equipment and drugs that we can use to cure illness. And if we just simply organize a system that will cover everybody, we can have the best healthcare system in the world. As a matter of fact, if you look at seniors on Medicare, their outcomes are comparable. Their outcomes are comparable to the rest of the world. It's the uninsured that are to some extent dragging us down. So with Medicare for all, we get real choice of our doctor and our hospital, first dollar coverage, comprehensive coverage. The security's there for all of us, cradle to grave, forever, for everyone. And $400 billion of administrative savings is what makes that happen. Because that's how much money we'll save by simplifying the system. By not having an army of bureaucrats on the insurance side warring with an army of bureaucrats in the doctor's offices and in the hospitals, struggling, pulling on Ben Franklin, or no, that's not enough, is it? How big a bill it would be. I don't know who's on the $1 million bill, do you guys know? But there's this war over money, and we're wasting so much money chasing the money, it is criminal when our fellow citizens are dying for lack of care. In all honesty, Obamacare is still going to leave 30 million people with no coverage. We know that for every 1,000 Americans who don't have coverage, one will die unnecessarily from illnesses that could have otherwise been treated had they been covered and gone to see the doctor. That's 30,000. The last time we lost that many people in a given year was World War II, and it goes on year after year after year. I see in my office a near miss every week. I see a wounding every month, and every few months I see a death from a healthcare system that just sucks a rat's toot. It's not the doctors, it's not the nurses. We're there, we can give the care, but we can't give the care to the patients because we aren't organized to do it. And that means we got to demand it. We can't just lay back and let our friends, neighbors, and family die unnecessarily so that Mr. Berlini can make $10 million a year. That's wrong, it's unjust. And so I encourage you. No justice, no peace.
Amen.